warm welcome from my side to this session of PCR entitled Master Tricuspid Regurgitation with Thrusted Technology using the TriClip, and we're going to show you a procedure step by step. I would also like to welcome my two colleagues who are experts in the field. First of all, Marta Sitges from Barcelona. She's very experienced, especially in the imaging of the tricuspid, but also of other parts of the heart, obviously, but also in tricuspid interventions. And we are also going to be joined by Stephan von Bardeleben from Mainz. He's one of the leading interventional cardiologists in the field of tricuspid regurgitation procedures. Objectives of the sessions is to learn about the imaging of tricuspid regurgitation, about the tricuspid valve, and also about the device. And we are going to use today the TriClip device, and there are many issues to be discussed, like the steering procedures, how to orient, how to stabilize the procedure in the tricuspid space, what the right trajectories are, and we're going to discuss this and lead you through this in the frame of this live case from Mainz. But before we start with the live case from Mainz, we're going to be instructed by Marta Sitges from Barcelona about the echocardiography of the tricuspid valve and the tricuspid valve during tricuspid valve procedures. And she's going to teach us again about the right, especially TOE images and the keys, how to assess the tricuspid valve regurgitation and how to guide the interventional cardiologist through the procedure. And therefore, it is my pleasure, without any further ado, to introduce Marta, and she's going to present to you within her presentation her view on the echocardiography of tricuspid valve. So Marta, it's yours.
Thank you very much for the nice introduction, and thanks for the invitation to participate here. So these are my disclosures. So what do we need when we are facing a procedure of TriClip? What do we really need? First of all, we need to see adequately the tricuspid valve. For that, we need to undergo a real systematic approach to the assessment of the valve, with a checklist not to forget anything. And this will allow us to really understand what's happening, what's going on with the valve, why the valve is leaking. And that's important, because if we don't understand the valve, we are not going to be able to treat it. Of course, as in any repair procedure, we need enough flexible tissue to grasp. And the last but not least important is that we need to work in a team approach. So we need to talk a common language within the team, and we really need to have a dedicated echocardiographies for these structural procedures. This is of utmost importance in most of the interventional procedures, but it's particularly important in the field of tricuspid valve repair, because the tricuspid valve has some more challenges in imaging. So always keep in mind this checklist that you have to have mentally with all the views that you need to see, both in 2D and color Doppler flow, to exactly correlate what you see in the functional anatomy of the valve and the color Doppler. There are, however, two key views that we must have always. We can discuss if both of them or one more than the other, but the two are key views. First, the biplane with from the right ventricular inflow and outflow view. So there we get this view in the transesophageal. So from a short axis, we have a modified short axis with the aorta in the middle, and we have the right ventricular inflow and outflow. So we see the tricuspid and the pulmonary valve, and the aortic valve in the middle. So from here we do, which is the blue line, we do a yellow line will be the orthogonal view, okay, that we have here. And this view is very useful because, as you know, it allows us for doing like a sweep from more anterior to posterior aspects of the valve. So here we can see in the biplane corresponding view, the gap, the length of the leaflets, and how the leaflets are moving. And if we see this exactly at the same time with the color Doppler flow, we can see exactly where the problem comes from, where the origin of the jet is. Second key view, not in this order of importance, but the other key view, transgastric short axis view. This is a view that some people are not used to, but it's just a matter of training. You go deep into the stomach, do a strong anteflexion, and you have this view of the three leaflets with the posterior leaflet, the septal, and the anterior, and simultaneous with color Doppler. And also from here, you can check, again, with the biplane view from here, you can check that you are really in plane, okay? So that you are really cutting the short axis parallel to the annulus, okay? This view is also useful for the procedure to guide the positioning, as we will see and later discuss. So these are the two must. Finally, very important, always pursue the best image quality. Small movements make the difference. These buttons of the echo machine are not decorative, so you have to use them in order to get always the best image quality. Don't worry, be patient, take your time, because your team is with you and they will understand, they know that this is not an easy task. So take your time and get the best image. Finally, for those who are very fond of 3D, is this essential? Is this a key player? Well, 3D is nice. It allows us to see more special, to have a more special idea of what's going on. But we know this is more challenging on the tricuspid, so don't be obsessed with 3D. It's very important for the biplane, but not so much for the zoom images. Finally, to sum up, must remember this systematic evaluation that you have to have in your head and mentally follow all the steps. Very important, as always, this team approach. We all work together. We are all important. Key views, inflow, outflow, together with the biplane and the transgastric short axis. Training on expertise, as usual, are of most importance. And don't worry, tricuspid valve imaging is much more difficult than the mitral or maybe the aortic, but not so much if you pursue and train. Thank you very much for your attention.
Well, thank you very much, Marta, for this beautiful introduction into the imaging of the tricuspid valve. Very, very beautiful imaging, which we not always are used to see from this type of patients, but we're getting better and better. That's at least my feeling. I think with this very nice introductory remarks, we should go without any further discussion to the first part of the live case, and I would like to hand over to Stephan von Bardeleben from Mainz. He's gonna give you some insights about this case and about the technology. So please, Stephan, go ahead.
Thank you very much, and we will start with the first part of the recording. So here we see the typical setting. We see that we're working in a hybrid OR, basically the stabilizer, and we're now discussing the characteristics of the patient. These are the disclosures. And here you can see the clinical presentation. We're talking about a 76-year-old male patient. He presents with New York Heart Association class 3, has a typical peripheral edema. And what we also recognize with these patients is a very prominent fatigue. As with more than 90% of the patient, he's in permanent atrial fibrillation. He has a CHEST-VASc score that you can see of 3. He has been treated with an LAA occluder in April of the same year due to gastrointestinal bleeding. He had a suspected dilatation, which was once seen as a dysplasia of the right ventricle, which was not true. Also, he has actually a sarcoidosis, but on biopsy and MRI, there is no cardiac involvement. There were some VT ablation years ago, 7 years ago, in the right ventricular outflow tract, so a very interesting setting in total. On physical examination, There is the typical elevated jugular pulse. He has also a hepatic backflow. The edema has been mentioned. The typical, Georg, we will discuss it later, the typical BNP elevation, also very typical, a 3-digit gamma GT liver enzyme elevation, which can also be used as a follow-up marker in these patients. GFR is still somehow preserved, which is a good situation for the prognostic outlook. We have a normal left ventricular ejection fraction. The right ventricular ejection fraction is reduced. We have an enlargement. The TAPSE, as you see, is markedly reduced. Fractional area change about 20-25%. Severe dilatation of the right heart, and TR grade 3 to 4 in the Hans-Verano classification, which has 5 grades. You can appreciate that the left heart is smaller than the right heart. We always do a right heart catheterization to characterize these patients and to exclude pure primary pulmonary hypertension, as well as subsystemic or systemic values of pressure in the right heart, which can be decremental. On the right heart, you see pure TTE as a startup. And you can appreciate that we have a long enough septal leaflet, which is a very important marker for the capability to do a leaflet repair. We don't have excessive tethering of the leaflets. And you can see that we see both planes here in a biplane assessment like Marta proposed it before. So these are the basic situations of this patient. We'll, of course, go into more detail during the procedure, and these are the first images in the procedure themselves. You see we're switching to a TOE. The left heart has no significant mitral regurgitation. This is mild. We see on the right-hand side that we have a slightly tethered, very long septal leaflet, which is beneficial actually for this therapy, as we will see later. You see the enlargement and also the wall motion abnormality on the free wall of the right ventricle. Now we're going into the inflow view on the left-hand side, which is one of the key views currently in the mid-esophageal setup. We see this because we're scanning across the left atrium to the right atrium. Now we're coming to the, from Marta explained, transgastric view. We can also see that we have a lead, pacemaker lead here, nicely in the posterior commissure between the septal leaflet and the posterior leaflet. This is not affecting the regurgitation, and you can nicely see it's a very long regurgitation, approximately 2.5 to 3 centimeters anterior posterior, but the separation to the free wall is not excessive. So, Georg, I think for the discussion, this is one of the keynotes actually to see whether we can treat these patients nicely. And perhaps you want to add, your very experienced interventional cardiologist, what would you add to this patient characteristics? Would you think they're beneficial, or what would be your impression so far?
Yeah, it's a perfectly chosen patient. Let's start from the scratch. Maybe Marta, we should involve you also. I think we all agree also we don't have a surgeon on the panel, so it's easy for us to agree. Not a patient for open heart surgery, looking at the right ventricle, looking at the TAPSE. This is going to be not a good or easy outcome, right?
Absolutely.
Absolutely. So I think this is a very nice case, as you said, Stephan, with very long leaflets. And the other thing is another demonstration that pacemakers are not per se a contraindication. Particularly these ones that are located so well in the posterior septal commissure.
So it's an ideal PCR course patient, and it will be my pleasure to show you actually a slide view into the future that is yet difficult actually to do, but which is fully automatic and may become more important in the next 2 or 3 years. And this is actually virtual reality or augmented reality in the tricuspid field. So here we see a new method actually of depicting this annulus and also the assessment of the valve. You can nicely see, and we will check this later, that we have an impaired opening between the anterior and the posterior leaflet. We can nicely, and this is totally deducted automatically by an algorithm from the TOE images of this very patient. where we can automatically assess the movement of the leaflets. And you see this is nicely done. And especially for training issues, this can have an additional value also for centers that are beginning. It is not yet ready for routine use, but I just wanted to give you a glimpse into the future. And this can help also, we will see later the results with the same technique. The clips are automatically identified, and we see the improvement and the impairment of leaflet motion with leaflet therapy. And I think this is a very interesting situation. So everybody thinks, and as you said, imaging in the tricuspid may be difficult, but I think very dedicated TOE images can have a very good quality. And in leaflet therapy, Georg, we don't need CT. So unlike annuloplasty or replacement, leaflet therapy totally relies, at least in our center, on three-dimensional or biplane echo. Full volume is rather a little bit a step back, is not totally needed, but can also be acquired. What is your impression or your tendency in Bonn, Georg?
Yeah, I think this is also a very important topic. Of course, you don't need CT for the leaflet device, but I would highly recommend to do a CT scan in order to have an idea what other therapy the patient could receive if you experience issues during the procedure, and if you want to bail out of the procedure, which is of course nowadays a rare scenario, but still. And then you know already maybe we can place a valve or whatever. But I would like to get back to the patient a bit more, because it's about the patient, also the procedure and also the device. And just want to add one more comment on the characteristics of the patient. I think it's a perfectly chosen patient for two other reasons. First of all, we have really a nice septal leaflet. Sometimes or frequently the septal leaflet is very small, it's very tethered, and here we have a perfect situation. And that's not only for the PCR course important, but it's also important for all selections of the patients. We should not start with an extremely challenging patient, and we should not overcome this technology. And this is a patient exactly for that technology. The second point I would like to add is we do have a nice culprit lesion. We have a valve where we know where we should start, probably at the anteroseptal commissural line, and we have a target for the device. And I think that's very important. If we do have a valve where we don't know where to start, this should be not the patient to go for in an unexperienced center.
So as we all know, the TriClip is uniquely designed for the right heart. We all know this. We have two different sizes, the NT size and the XT size. The difference is the arm length that engages the leaflets, 9 millimeters or 1.2 centimeters. And as with surgical repair, leaflet repair on the tricuspid relies on a very good coaptation length. So we decided for this patient to try the larger size, the XT size, which is predominantly used in Europe. In the US, there's a little bit more use of the NT size. The changes also to the TriClip are that we have dedicated knobs to steer down to the valve, to get off a septal hugger, and to have a very short curve at the tip of the device in order to engage, even if the right atrium should be a little bit more shallow or smaller. Georg, what are your impressions? You reported on the Triluminate trial that was done with this device. What are your impressions at your center?
I think it's a major advantage to use this device, especially the different steering capabilities in the sheath, because in the initial procedures we always had this septal hugger, and this can be easily overcome by this device. I think this is one of the major advantages. And the second one, of course, is that we have the larger clip arms available. Tricuspid is a large valve. I think we should go on with your live presentation.
Okay, yes. So we aligned the system blue line by blue line, as we can do it now with the TriClip device. We will now go into the system. We're here at the bicable view first. So showing the device is typically we set up the C-arm slightly in RAO and cranial position. And you can nicely see also here an amulet LAA occluder. We're now steering down with two knobs only. This is the flex knob. We're straddled, slightly under-straddled, as you see, as we keep the middle marker, not the last marker there. So we have enough space to steer down. We use two knobs here, which is the plus knob that we all know, and an additional knob that is the flex and extension knob. And this flex knob steers us directly down to the valve. We go slightly lateral with the first box. You can see this with my left hand at the right part of the image where you see the device. So we're counterclock orientated to get down anterior to the tricuspid valve. And now we're switching into the inflow view across the left atrium. So this is a mid-esophageal TOE view where we now show the septal hugging situation that Georg nicely mentioned. And we can overcome septal hugging by using a new knob here, which is the L knob. This brings us to the free lateral wall and improves the trajectory to the tricuspid ring and to the tricuspid valve. And you can already see that we do this. We're adjusting then septally with the clip itself, so coming from the interior leaflet and now moving into the opening of the tricuspid valve. This is a situation that can now be done in minutes. So it has become much, much easier for everyone. And I have not experienced in my TriClip experience now any patient where I could not prevent a septal hugger with the system. You agree?
Absolutely. So Marta, what's your feeling about the imaging so far?
So far, imaging looks okay. I mean, here in the biplane, the other view, the septal leaflet is perfectly seen, and also the mural one also. So good.
Yeah, we showed a little bit in this video the movement to the septum and from the septum because the original sound is not on. This has not been totally synchronized now, but here you see that we're pointing to the apex of the inflow chamber. And this is very nice because in the past, sometimes the clip arms were too low or too high on the septal or on the anterior leaflet, and this can be easily overcome. So if we want to get higher on the septal, we put more L on the knob, and we then move secondarily back to the septum. This heightens the clip arm on the septum, and we can do the opposite in provoking a septal hugger in order to get higher on the anterior or posterior leaflet. So this is a very simple box turning and a very simple one knob control now with this new system. Here we're using 3D to do this. It's not the preferred or the needed technique. It's just for actually depiction of the position of the clip. We see on the right-hand side at 3 o'clock the aorta. We see the anterior leaflet at the lower right-hand side. The posterior leaflet and the pacemaker is on the left. And this gives us a very nice view where actually the clip is positioned. Now I think we're opening the clip. As you will see, you see the clip arms directly, so I don't have to re-rotate. I do this from fluoro, and in this regards, I changed actually from an echocardiographer's view to more interventional aspect, as we're rotating and controlling rotation almost only on fluoroscopy with some adjustments in echocardiography. Now you see this three-dimensional image. You can nicely see the clip arms are orientated up and down. So very nice to the perpendicular side of the septal leaflet. That is the important anchor for this device situation. We're now changing, you see that, into the transgastric view. You can easily see control also, and this is also something we do very nicely at our side. The echocardiographer in Mainz has its own fluoroscopy image screen. So you can control the TOE probe nicely in fluoroscopy. So you see your transgastric angulation, whether we have a 90-degree. And what you also pointed out, it's very important that the annulus is directly going from 12 o'clock to 6 o'clock, so that we see the leaflet tips always at the same position side. Otherwise, we think the valve is opening further. If you go too atrial, you artificially increase the perception of the gap that you have. And if you go too much into the ventricle, you only see cords. So the secret is to get here also in a slightly, in a position where the leaflet tips are directly in the middle line of the right image. Marta, do you want to give some additional comments on this?
Thank you, Stephan. No, this is exactly what we said at the beginning. So it's important to use also the biplane to check that you have the right transgastric view. Yeah, very important.
And we like to keep, Georg, perhaps you would like to say how you do it. We keep the clip closed, because if the clip is in the middle of the commissure, you can now move up and down to the selected region where you want to engage the clip if it's closed. So we always go in tricuspid in, also with the first clip, in a closed position. Do you do that the same, or do you have other techniques or tips for the audience?
Actually, in most of the cases, we go in with an open clip, but I think this is a matter of taste, more or less. It's a huge valve, and we're gonna orient usually the clip in the atrium and go in right away where we want to go. But I think it doesn't really matter. If we have 3 clips in, we should go in with a closed one, because space is going to be limited. There I would agree, but I can also follow your strategy. So imaging is very perfect, and trajectory also, right, Marta?
Yeah, you just use the transesophageal for all the trajectory, and you just go then in the very end to the transgastric, Stephan. Is that so?
Yes. I only recontrol 5 degrees or so in the transgastric. So I'm already orientated. I do this in the inflow and generated 4-chamber view. And if I see the clip arms there nicely, I already have an orientation that has only to be changed by 5 or 10 degrees. And this is perfectly possible in the transgastric view then. So I do the fine tuning there. And as soon as the leaflets get open and close independently, you're never engaged with any cords, or you don't have any trouble. You simply have to wait for the cardiac cycle. And I think we'll see when we really engage the clip that this is very important, that you only move up in systole when the valve is closed. This is very important because it's such a large valve. So if I move up in diastole, I have an open valve and I can pull the clip through. So the movement should be just adjusted to the heart cycle. That's at least our strategy. There are always many ways to roam, but we can discuss these different strategies here.
I mean, to be very fair, also for the audience, this is perfect imaging, and sometimes we only have one of these images. Sometimes we have only a good transgastric view because we have mirroring by an implant, by an aortic valve, for example, sitting in there. But here we really have the choice between these 2 different views, which is very educational for the audience.
Yeah.
And I'd like to say that we really need a structural heart imager. So we have 5 persons that do interventional echocardiography at our site. It is really important because the interventionist, I'm not important in this procedure. The imager is important. It's like, always say, like a rally car. You need the road book next to you because you don't know the road behind the next tree. So the team is very
I'm sorry, I disagree. I think everybody's important in the team. You are also very important.
Thank you, but we always have to see something, and there I go totally with Georg. So now you see we're actually in the valve where we control the depth of the system, and we simply only go 1.2 centimeters into the ventricle, no more. And the reason for that is that the chordal structure of the tricuspid is very dense and has to be respected. So we open the clip, actually, I know that some go in open, but we open the clip directly at the leaflet tip. And this enables us to really dive into the upper structures. Sometimes we have chordal ladder structures that are cross links between chords. And if you go too deep into the ventricle and then pull up again, you sometimes get entangled too deep. And this is why we adopted this technique. So we precisely here try to be in the middle. We have seen that the anterior posterior leaflet is slightly linked. And normally, Georg said it in the beginning, I also like to do 70 or 80% of my tricuspid treatments are anteroseptal. So from the anterior leaflet, which is typically larger, to the septal leaflet. But here, the septal leaflet is longer and better structured in the posterior part. And because we have a connection between the anterior and posterior leaflet, we decided to go at the most anterior portion of the posterior leaflet, actually, to do this procedure. And you see me moving now posterior. I do this in the transgastric space. We control actually the penetration into the ventricle with the biplane image on the right side. Now I stop already. I don't go below the papillary muscle heads of the anterior papillary muscle of the tricuspid valve. And now we slowly open the clip and already control the rotation. This can be done with the clip. It's just 20 degrees open. We see this in the transgastric view. And now I'm adapting to the situation of the septal leaflet. And you will see in the procedure that I correct only once by 5 degrees. And this changes the regurgitation quite well. So we now open, you see the white knob, my right hand, I'm turning the clip open. I'm in the ventricle of the right heart. And now you see the arms, and the arms are directly orientated 9 o'clock, 3 o'clock. So I'm almost there. I only have to change perhaps half an hour, no more, which is perfectly possible now in the ventricle. And you see that my fluoroscopy image on the right-hand side gives me the rotation. I don't see the clip arms there. So this is my reference point for the rotation of the clip. We see we're free from the lead, that's perfectly in the posterior commissure. And now we're trying to get the leaflet tips. And you see the lines are now depicting in this procedure. Because the anterior leaflet is a little bit and posterior leaflet are a little bit down, I first go slightly to the free wall and I now engage the leaflet. What I'm looking for is that the separation of the line of the leaflet tips is staying within the clip. And you see I'm moving up, slowly moving up in a slight V shape. And suddenly you will see that the clip is in the septal leaflet. You nicely see this already in these images. And also that the line of the anterior posterior leaflet is not leaving the clip anymore. And if I see that, I know that the leaflets are within the clip. You slightly move up. Now I'm V-shaping the clip, you see that? And pulling up. So now this is nice to see that the middle of the anterior posterior leaflet is in the clip range. So the leaflet tip line doesn't go to the free wall anymore. This tells me the engagement, and also the septal is now engaged. And I slightly pull up 2 millimeters, 3 millimeters, always in systole. And this now I'm moving slightly back to the septum to engage this leaflet a little bit more. And you can see that the leaflet motion is impaired because the leaflets are in the clip themselves. Now we get the biplane image, and here you see septal leaflet and the middle of the anterior posterior leaflet is nicely on the clip. So this is our control view. We use this. But I like to use a lot of the transgastric view that you said is a second reference view for this device.
Yeah, but sometimes, sorry for interrupting you, sometimes it's not so easy to depict as in this beautiful case. And therefore, in that view, the right lower corner view is key. If you can do this, there you can nicely judge the relation of the clip to your leaflets. Beautifully to be seen in that slide.
Thank you. Yeah, it's a very important view, and I don't advocate to do only the one or the other. It's always good to do both, Georg. The rotation is better seen in transgastric.
Maybe I can interrupt also for a second, but you can also see on this so-called commissure view that you are not in the anterior commissure, but you're more in the center of the valve.
Absolutely, and this is because it's partially bicuspid, this valve. This is why I chose a very central position to be effective. In the first attempt, I wanted to do 2 clips in this case, but I switched my strategy to a 1 clip approach because I saw that the separation, as you see, I'm engaging both the anterior and the posterior. This anterior posterior is partially bicuspid. This was why I changed this strategy a little bit. Here I'm respecting the tip of the septal leaflet. Now I'm controlling a little bit more to go counterclockwise, as you can see, in order to have the coaptation line 90 degrees to the clip arms. And this is something you do not see on the mid-esophageal or deep esophageal views. This rotation can only be controlled on transgastric views. Marta.
Yeah, so I wanted to highlight this because you show a super nice transgastric view, but I want to highlight that we need to master the 2 key views because, as Georg said, sometimes you don't have such a nice transgastric, and when you have this nice transgastric, it's very good to do the grasping there, but you really need to master both because it's good to have both to double check as you have done. So you have it on the transgastric, but then you go back to the transesophageal and biplane, and you have double check. So particularly for not so experienced interventionists, I mean, I think that's super useful. And also for the strategy at the beginning, maybe it's also good to check the perpendicularity before entering the transgastric. So in the
you see the result here.
They just close the clip.
Yes.
And grasp both leaflets very nicely. So Stephan, go on.
Yes, so we will once simply slightly move it slightly more posterior. We have a jet here that you see. So we go to try to have 2 trace jets around, but you see this only 1 clip has been highly effective. We had an anterior posterior situation of 2.5 centimeters, and now we're at 4 millimeters or something. So you see that these clips can be highly effective. And what they do is that we enforce both leaflets, the septal leaflet and the anterior posterior leaflet, to get into a coaptation length. And there we feel that the XT clip is highly effective, as you can see in this case. So this was a short reopening and reclosing. So I readjusted a little bit the rotation only here. I kept the V position, so I did not lose the leaflets at all. I simply pulled up 1 or 2 millimeters and changed slightly counterclock. And this is now on a replay, and you see it's even nicer. So you do not have to be afraid to do this. And Georg, I think this looks good as a result.
Yeah, this looks perfect. Absolutely. Sometimes you underestimate the residual jet in the transgastric view, but here we see already the esophageal views, which show also a nice result. Just small.
There's a small jet left, but we will see on the follow-up, we have the follow-up image also here, that this further disappears. There is some jet, that's true, but we discussed whether taking a second posterior clip, but we decided, because we have a nice distance, as you see in fluoroscopy, to the pacemaker lead, we discussed to leave it actually in a situation where we have a good distance, and to enable both systems when the ventricle gets under volume load or less volume, that we don't get into touch to another system. And we of course also have the follow-up pictures of this case on discharge, and you will nicely see that the strategy worked out well.
Yeah, that's a perfect result already. I also wouldn't have changed the clip. I mean, to be very frank, we're not going to be able to nail it down to 0 in most of the cases. So if we leave the table with TR1 or even TR2, this is going to be usually a perfect result, and we'll discuss that in a second. For the patient, it's usually quite advantageous. They benefit also from reduction from TR4 or 5 down to TR2.
Yes.
So, would you also?
Absolutely agree. I think that you show very nicely that taking your time to ensure a very good grasping and checking everything, and even moving a little bit to improve the grasping on the septal, was key to have this beautiful result. So That's what I wanted to enhance. No, take your time. We have time. Everything is stable, so we have to make it perfect.
I would like to stress, and perhaps we can discuss about the choice of the clip length. I showed in the first images that we have the NT and we have the XT. So there are two mentalities in Europe and the US. In the US, more people are using the NT device. Our center is a 98% XT user. Sometimes in the interior commissures, if you need that, there are rare cases when I also use an NT, but it's rather rare. What about your side, Georg? What would you prefer for the tricuspid valve?
100%. I don't want to punish myself.
Yeah. I agree. We can discuss about the 2%, but as I already said, we are also 98 to 100% XT. But in the US, this is sometimes in certain centers, it's criticized, and they say it's too dangerous for the leaflets of the tricuspid valve. And I would highlight that we haven't seen tears, etc. You simply have to be very cautious on what areas of the tricuspid you are using your clips. And it's not a matter of size. The difference of the arms is only 3 millimeters. This is not game changing, but the XT device is more effective in our experience. We did the first 100 because there was no XT actually with the NT device, but we're getting absolutely used to the XT in the tricuspid, and it's also our clip of preference. The method of implanting would be totally the same.
How about Marta at your side?
More or less, it's a similar. Sorry. I think the XT is perfect for the tricuspid valve because it's treating larger leaflets, and in the tricuspid, the problem is the annulus dilatation. So leaflets are large. It's a completely different story from the mitral valve, so from functional MR, I mean. So in our experience, it's the same, 90% or 95% XTR, and only for the commissures, NT. That's it.
Let's go on with the case, with the deployment and the final result.
Yes, here we already deployed the clip. The clip it's very short, but it was very stable. So this is also a very good sign. You see it also on echo, and now the fluoroscopy is on. You see it doesn't tilt, it doesn't move. It's that's always a good situation for the decision. You see we have some mild or 1 to 2 plus residual regurgitation near the clip, but we will see that this is overcome because the patient now is getting under more and more diuresis, and we will also show the discharge images, which are mild. So it's very important that we don't have to overdo it because we keep a large opening. This patient had only 2 millimeters mercury mean gradient. So it's very important to keep this low, especially in the right inflow. Here you see the Doppler, it's only 1 to 2, as you can see. So there's no stenosis whatsoever. And I would highlight that our mean gradients across the valve should be much lower than on the mitral valve. So 5 is not acceptable. Typically, these patients go off with a mean gradient of 1 or 2, Georg, because there is no situation. We don't have the lung in between. We directly have the venous system and the superior and inferior cable. So it's very important to really have these low values. You see the engagement nicely. So the clip is engaged to the septal leaflet. We chose a position that is posterior. One could have discussed to go slightly more anterior, but I think there's a nice opening. You see the pacemaker is unaffected. It's still nicely in the commissure at the annulus, so not involving too much pressure on the clip, which is important to prevent an SLDA. We were quite happy with this situation. If the video is at the end, we will see also the discharge images of this special case, and you can see that the gap is gone. Also, the interior leaflet, Georg, is contacting now nicely the septum, and this has reduced these 2.5 centimeter regurgitant situation now to 4 or 5 millimeters, and I think this is one of the key issues.
Yeah, it's a very nice result. Maybe Marta, you want to comment also on this gradient issue. What would be your accept threshold, and how would you measure this? How would you assess this? Are there any any pitfalls?
No, we assess in the regular way, just in the RV inflow, usually very parallel to the flow, of course, and more or less what we accept at most is 2 millimeters mercury. So this is the tricuspid valve, as Stephan said, it's not the mitral. We cannot go higher, and we typically have gradients around 1.5. So 2 is kind of our limit. As a mean gradient for the tricuspid,
usually it's almost it's not impossible, but you have to really be serious about getting a higher gradient with this technique in this huge valve. So, but here it's really looking great. I mean, 3D. We just discussed 3D. You made this comment, Marta, at the beginning. If I recall that correctly, you don't really need it. Is that what you said?
I mean, we need a 3D probe for sure to do biplanes. That's for sure. But we are not so fond of full volume. Not so fond, but not so obsessed with full volume. So if you have a nice full volume, it's useful, particularly for assessing perpendicularity, also sometimes for guiding the steering, as Stephan showed. But if you don't have a nice full volume, don't worry. What you for sure need is a transgastric and an RB inflow-outflow biplane. So these are the musts.
My impression is always if you do have nice 3D volumes, you don't need them, because the other imaging is usually also perfect.
This shows also an automatic analysis that we have in the room. And here you see the nice position of the clip in the posterior. And the system also detected nicely that we had a 2/3 gluing of the interior to the posterior leaflet. So this separation of the interior posterior was impaired, and this was automatically detected by the algorithm. So we also only have used about 5 to 10 procedures with this new technique, but it seems to be quite promising. And I just wanted to tell you, it detects the clip type, the clip size, and the insertion of the leaflets. And you can nicely see here in red how deep the insertion of the leaflet gets into the clip, because the algorithm detects before and after the clip and highlights how much leaflet tissue from the analysis before is really entering into the clip. So this is something we had to do manually in the past 8 years. But Georg, I think it's at least a glimpse into the future. I don't say it's a 30-second analysis yet, but we're really heading here into a very interesting artificial intelligence way, not only in radiology but also in cardiology.
Absolutely, I absolutely agree, Stephan. This is the future, not only for visualization, which is what we have now, but for planification. I think that when we have these tools and we can measure online the length of the leaflet that we have inside, and also that we can planify, so we would go there with the strategy, okay, because we have already played with the machine and try to put one clip here, one there, and what's going on. So I absolutely agree, this is the future, the near future. Yeah, I don't know, maybe for the ECG, but it'll take some more time for the imaging. Our KI Institute tells us. Let's go to the discharge situation of the patient.
Yes. I think here we see that, and you can see that it's really not a moderate TR at all. And this is also one of the nice situations. If we're able in the procedure already to decrease the regurgitant death by 80%, actually we see, and you can nicely see also that the size and the contraction of the ventricle is not impaired. It's rather a little bit better. And what we sometimes see is that these patients diurese very well after the clip support and get massively better than before. And this is an added value of the device. Georg.
Thank you so much. That was really a superb case. Nicely performed, and for example, very important, the selection of the patient. This is of extreme importance for having a successful procedure. Maybe that's a very nice remark to go to the triluminate data. for a second, because we see also some signs of right ventricular remodeling. If we could have the slides for a second. As you may know, the TriLuminate study was a single-arm study in 21 sites in Europe and the United States, and we studied 85 patients prospectively and looked at the safety and also at the efficacy of the TriClip device in patients with severe tricuspid regurgitation. And here you can see already the results. On the left side, you can see in this early experience, admittedly, we were able to reduce tricuspid regurgitation at least by 1 grade using the 5-grade scale of Becky-Hahn in almost 90% of the patients. And more than 70% of the patients we reduced it by 2 grades or even more. And if you want to see it on a more granular fashion on the right side, you can easily appreciate on the left column there that most of the patients entered the trial with severe, massive, or even torrential tricuspid regurgitation. And after 1 year, this data just got published in JACC as we speak. After 1 year, 71% of the patients were still in TR1 or 2 when they presented again to their center. And this was followed also by a nice clinical improvement, as you can see here. On the left side, you can see the New York Heart Association heart failure symptoms as judged by the study doctor. And easily to depict, most of the patients entered the study in New York Heart 3 or 4. And after 1 year, most of the patients, 83% of the patients were in New York Heart 1 and 2. And this is mirrored also by the self-assessment on the right side, KCCU score, more than 20 points of gain, even after 1 year. So a sustained gain in life, in quality of life in that patient group. And this is the slide I referred to already. This is evidence for right heart remodeling, I should say. Here you can see the right ventricular end-diastolic volume, the right atrial volume in the middle, and on the right side, the TAPSE, which is a crude parameter of right ventricular performance, and they all guide us into the right direction and showing right ventricular remodeling. And at the end, I would like to just share and point this out again. This is a very safe and very calm procedure, as shown perfectly by the MINDS team. Within the TriLuminate study, we didn't lose 1 patient on the left side. This is 30 days adverse event rate. There was no single severe issue within this 30 days. And on the right side, you see the 1 year data. There were 6 deaths, 4 for cardiovascular reason. And this is quite low if you would compare it to a historical control. And with this, do you know already how the patient is doing over time? When did you do the procedure? The
patient is doing good. It's about a month. We also have now the 1 month control, but it's very recent. The situation is absolutely stable. Something we also have seen in the just recently accepted 1 year follow-up of the TriLuminate, which is accepted in JACC. Actually, and I think it's very important to see that 30-day results highlight already the 1 year results. So one could have thought that there is a decrement in the efficacy, but we see in the majority, not in all patients, but in the majority of patients, we see a very nice stability, which is impressive for a leaflet therapy that surgeons wouldn't address. So this is a totally different approach to surgery. They are only on annuloplasty approaches. And I think always all strategies have to be revisited over the years, Georg. Huh?
Yeah, sure. Marta, your last word.
Just one question, Stephan. Have you reduced the diuretics on this patient?
We don't do this in the first month. Never stop the diuretics at all. That's important, but you can reduce them up to 50% over time. But in the first month, we keep them as is for the first period. And if we see the patient is diuresing well, is getting a smaller ventricle, etc., we sometimes adapt the dose, but we tell the patient to keep diuretics in their regimen, not to stop everything, because then you would decrement the efficacy of the clip alone, but you don't have to maintain the same dose throughout the first year. That's not necessary. Georg, what do you do?
I totally agree. I think we have to close the session by now. I think that was a very vivid discussion, a perfect case from Mainz. And I hope we could show you that, first of all, tricuspid regurgitation is extremely important. It's very frequent, high prevalence. It's related to poor outcome, and that we can treat it. That we have dedicated treatment for tricuspid regurgitation using the TriClip device, which is a very standardized procedure along with the imaging. And we already believe that this can help the patients. We have seen that from the TriLuminate study, that we can also improve the clinical situation of the patients. The TriLuminate pivotal is running right now already, probably showing us that we can also improve the outcome, the actual outcome of the patient. With this, I would like to close. Thank you again, Marta and Stephan, for your contribution. I hope you enjoyed the session as we did, and have a nice day and stay healthy. Thank you. Hello, everybody. One question was, how far should we reduce tricuspid regurgitation, and what's the clinical benefit? And actually, we don't know for sure, but what we have seen so far in the uncontrolled single-arm studies is that even if we reduce, let's say, torrential to severe, there is clinical benefit to the patient, and there is reduction of heart failure symptoms, and there is increase in exercise capacity. Of course, it seems to be better if we are able to reduce it even further to mild, or maybe even to trace, but this is still absolutely open. We don't have the data yet, and frankly, we don't have the devices yet to reduce all patients to mild or even moderate. Maybe we'll know about this also with replacement.
Absolutely. So other questions that arose were, there are tricuspid valves with more than 3 leaflets. Are we able to treat them with an edge-to-edge device, Georg? That was another question.
Yeah, why don't you take it?
Okay, so we showed a case in a partial bicuspid situation. If we have a lot of sublobally, of course, some size of the leaflets is important in order not to open the indentations between the leaflets. So if you have a tricuspid valve with 5 subleaflets, etc., you will be forced into some sort of Glover technique, so to address more than 1 leaflet. And also, I would like to highlight the importance of the septal leaflet as the anchor leaflet to really perform this technique. At least 1 or not more than 2 subleaflets on the septal side are also very important to achieve a good result. Georg, what is your opinion?
I totally agree. I think if you start your program, you should try to stick to 3 leaflet anatomy if possible, or if there are 4 large leaflets and not too many indentations. I totally agree, but it's certainly the more complex procedure. I mean, the best situation is if you have a bicuspid situation or bicuspidalization situation, then you usually can place a clip in the center of the valve, but that's also rare. But I totally agree.
We got another question from the chat directly via email from Maurizio, and he was asking, or one of the audience is asking, about potential damage to the esophagus by changing between the transgastral and the transesophageal views in the interventions. Is there more bleeding? These patients have a child situation. They have perhaps varicosis of the esophagus. So how high is the bleeding rate for these patients in the intervention? It's low, but I have seen cases in which we have seen erosions in the esophagus and also in the stomach. It's a fair point. I think we should consider it. And some of these patients really do have liver issues and maybe have had a bleeding, an upper GI bleeding, and therefore we should be careful about this. But it's not a very prevalent issue, isn't it? I totally agree. The same for us. We had 1 or 2 cases in more than 200. So I think it's a 1%, 2% issue. So you should be cautious. Of course, if you move up and down, don't do it if you're very angulated with the TOE probe, but I totally agree. I think the last 15 seconds are on. So back to you, Georg, for the final remark.
Yeah, we are already above. That's how I interpret the clock. So
you're correct.
Fun having this session together. I think we have to close. Thank you very much, and a very please have a very nice and successful convention. Thank you so much. Bye.
Thank you.